Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in the United States. It's my pleasure to welcome you to our 63rd webinar exploring strategies and new technologies that's helping us advance progress toward elimination goals for hepatitis B and hepatitis C. For this edition of our webinar series, we're going to be looking at how to integrate routine HCV testing and linkages to care in health systems in the United States. We're really fortunate to have safe and highly effective cures for hepatitis C that can indeed cure over 95% of infected persons. But our challenge is to get those persons diagnosed and referred to care so they can receive those life-saving treatments. And we're going to be exploring the different strategies in that regard for the United States. I want to thank our sponsor today, Roche, that has made this webinar possible. And we appreciate that. But I'd like to also add that Roche had no input on the agenda today or the selection of speakers. Next slide, please. So welcome, everyone. Just please submit your questions as we go through our agenda today of our 4 excellent speakers. Submit your questions to the Q&A function. We'll do our best to answer those as we move along. And then those that are really prominent, we will seek to put those into a panel discussion at the very end. This webinar is recorded. It's available on our website at globalhep.org, joining the others webinars that have been recorded and are available there, along with slide presentations that you'll be seeing here in a few moments. To stay up to date on the activities of the Coalition and a future edition of the webinar series, sign up for our monthly newsletter at globalhep.org. Next slide, please. And so all the materials are available on our website. Go to the QR code and click on that and go to it directly. But it's a very rich resource of video presentations of the whole seminars, of the whole session today in full, as well as the different speakers will be individually available, again, together with the slide presentations. Next slide. So our agenda today, we're going to be exploring strategies for how to identify and screen persons that are at increased risk for HCV infection, persons who use drugs. Then we look at examples of integrating hepatitis C testing as a routine clinical screening service at the Harborview Medical Center in Seattle and by Kaiser Permanente Mid-Atlantic region in the Maryland, Virginia area, and then look at the integration of HCV testing within the Community Health Center in Kansas City, Missouri. So let's get started with Dr. Alysse Wurcel, who's an associate professor at Boston Medical Center, that's going to be sharing her study involving a number of medical centers to look at their HCV and HIV screening of persons who inject drugs. Dr. Wurcel?
Hi, thanks so much. Hopefully everyone can hear me okay, and I'll share my screen. I was at Tufts Medical Center in Boston, right down the road, for about 12 years. And last month I moved to Boston Medical Center. I'm really excited to be asked to join you all and talk about my study, or our study. As you can see, it was, so sharing. Okay. Oops, there we go. So I'm going to talk about the study, the Hep C testing in hospitalized people who use drugs. And I guess I'm just going to start off, like, do you ever feel like Sisyphus? And I understand this is every clinician, every public health worker has their thing that they're interested in. This is what brings us to medicine and public health. And, my husband's a neurointensivist. He probably has things that he feels like Sisyphus about, things that are should be easy but are hard. Why is this boulder so hard? And my boulder is just infectious diseases testing as it relates to people who are incarcerated or people who are hospitalized, and especially people who use drugs. So this is a study that came out a while ago in Annals, and it basically shows how Hep C is passed and models what we need to do to stop Hep C from being passed. And although this is populations in prisons and populations in the community, I'd like you to sort of think about populations in hospitals and populations in the community. We don't want to think about hospitals as being institutions, but they definitely they're a separate entity from existence in the community. They are opportunities. They also block opportunities, whether it be jobs or spending time with family, or paying your rent or having a cigarette. Although as people who are interested in healthcare, it may be counterintuitive to think about hospitals as prisons. They're institutions that sometimes provide care when other people can't, and they're institutions that prevent care sometimes or prevent the person from going on. So as it relates to people in the hospital, identifying Hep C, if you're in the hospital, is really important to stop the spread of hepatitis C. And this was an article that just came out in 2020, actually, I guess 4 years ago, which just sort of talks about how at least based on modeling, it takes a really long time to get people a diagnosis of hepatitis C. There's so many things that happen in their course of their life. And in this modeling study, it just sort of suggested about 4 years between infection and Hep C diagnosis. For most people who use drugs, especially in Northern America, or at least in the Northern United States, it's sort of like a known entity that you'll probably get hepatitis C if you share drugs within about a year, probably less, just because it's so prevalent. But there is a delay in definitely getting diagnosis, especially of chronic viral hepatitis. So what are the systems at play to prevent Hep C testing in the inpatient setting? I know there's problems with the socio-ecological model. I'm just going to build broadly off of it to say there's individual knowledge, attitudes, and skills, whether it be the clinician or the nurse that thinks that the inpatient setting is not the right time, that Hep C is an outpatient issue. There are interpersonal, family and friend and social networks things where people who use drugs don't think Hep C is a big issue. There's a article about this that says Hep C is the common cold. Why should we, I'm trying to work on someone and prevent them from overdosing. Why would I waste 5 minutes of my time even discussing Hep C when I could use those 5 minutes to better discuss overdose risk or better discuss other tools of harm reduction? There's organizational goals. I think, as it relates to Hep C treatment and initiation, it is counter to the hospital finances to treat and test Hep C. It is counter. It's the same. If you find something, you have to deal with it. And now you found Hep C, but you're going to tell the person you can't pay for their Hep C treatment while they're hospitalized. So I think it really goes counter to the model, what the hospital wants. In the community, and even as it relates to public policy, how we continue to marginalize and make people who use drugs as the other. They're the other, the undeserving, the people that are dehumanized and don't deserve good care. So I think all of those things probably coalesce into why inpatient Hep C testing is not prioritized. And I've been guilty of this too. If I'm on the ward seeing someone who just overdosed or has massive endocarditis, the idea of whether I'm not going to counsel them about Hep C, maybe that I've been guilty of this too. This is not, I take responsibility. So, I'm up in Massachusetts. We've had HIV outbreaks. I've diagnosed so many people with HIV. I continue to diagnose so many people with HIV. We have intense drug overdose rates. I know we are happy that overall the overdose rates are going down, but there's still way too many overdoses happening. And then we are one of the sites in Massachusetts that has done some of the really, everyone's doing great work. We've been able to do sort of look at who these new cases are for Hep C, where are they happening? And we know that people who inject drugs make up the vast majority of people who are getting hepatitis C, at least right now. So, and then we also have this integrated viral hepatitis surveillance and prevention program, and I benefited from this, and I work with a Mass DPH, and so Massachusetts is one of the sites that's really tracking hepatitis C. I wrote this paper where I tried to implement a bundle to improve HIV testing during hospitalization for people who inject drugs. I'm using this as just a background to show that I've been trying to do this for a decent amount of time. We came up with something called the ABCs of care for people who use drugs, which is test and vaccinate for hepatitis, test for HIV, offer MWD, and prescribe Narcan. We came up with buttons. You know you're legit once you come up with a button. And then we actually came up with a jingle related to Michael Jackson's ABCs. And we made a YouTube video, just trying to get people to engage in this sort of bundled approach to care for people who use drugs. That leads me to this paper, which was just published in Open Forum Infectious Diseases. I want to tell you, this paper had no funding to push it forward, so it's just based on the grit and the interest of the investigators. To get anyone to agree on anything is really hard, whether it be Dunkin's versus Starbucks. So you can imagine, like, to get all these people to come together on methodology and to write a paper, it was sort of a monumental feat. So I'm so lucky that I got to work with them and this idea came. But the reason why we did this paper, the reason I was interested in doing this paper is in Massachusetts, you need consent to test someone for HIV. You do not need consent to test someone for hepatitis C. And actually, Massachusetts has some of the strictest rules of the whole country as it relates to HIV information, all prepared in the context of people who were, denied health insurance and denied things back 20, 25 years, 30 years ago when they were diagnosed. But I thought it was interesting to look at the different states. So these are the states that are involved in our study: California, Texas, Colorado, Missouri, Alabama, Illinois, New York, Vermont, Maine, Connecticut, and Massachusetts. So we have a wide breadth of states. I just put up there their HIV prevalence. So you can see their different prevalences of HIV, with California, Texas, and New York being one of the higher ones. But that's what, this was our group of researchers that we came, and people are like, well, how did this happen? How did you choose these states? I wish I could say there were robust research methods. It's just interested people who had time to go to their IRBs, get data, or already had data sets already existing. Okay, so this is table 2 from our study. It is entitled HIV and Hep C testing and positive rates in people who use drugs admitted to 11 hospitals and hospital systems. And so on the left, you can see all the different hospital systems and the number of people who use drug admissions. And, you know, the N is very, Parkland Hospital likely had more people who use drugs admissions than Claire, but each hospital contributed the data set that they were able to have. So some places contributed a data set that they had for all of the addiction medicine consults. Some people, like at Tufts, I was able to do a review of all of the admissions. So they're not the same cohort necessarily bringing to the table, but each was able to bring to the table people who use drugs. You can then see after that, the number of HIV tests completed was incredibly variable. So for example, at Barnes Hospital in Missouri, 41% of people who use drugs had an HIV test. In Montefiore, it was 17%. At my institution, it was 24%. Certain places like San Francisco General Hospital is 78%. So there's incredible variability of who uses drugs and who gets an HIV test. I was interested specifically in whether the idea of verbal consent required had an impact, and it did not, at least on like a broad chi-square kind of approach. Whether or not verbal consent was required to do HIV testing, at least from this study, did not clearly impact HIV testing. And then Hep C testing in these people who use drugs admitted to the hospital was either the same or lower than HIV testing, which kind of ran counter to what I thought would happen. I thought there would be more Hep C testing than HIV testing, because Hep C does not have the same sort of discussions mandated around it. There were some problems about that, and given that like maybe a lot of people said that they had Hep C, so they didn't get a Hep C antibody, and they would get a Hep C viral load as well. But a lot of people who use drugs are not getting Hep C testing, whether it be antibody or viral load completed when they're in the hospital. And then lastly, you know, at least when I was at Tufts, reflex Hep C viral load from antibody testing was not possible. The amount of time and energy and that went into discussing why this was not possible, amount of meetings, I don't understand it entirely. It's about number of tubes and billing and all these other things. I guess if there could be anything that could come from a policy change, it'd be that all hospitals need to have this available, that I have a positive Hep C antibody would reflex automatically to a viral load. It feels like the right thing to do. I'm not sure why some systems are able to do it and some systems are not. I know it's way more complicated than that. There's lab techs and lab inlets, but there's a lot more there. So I guess I just want to take home the message of heterogeneity. There's total heterogeneity across how we manage people who use drugs, and not just heterogeneity, but we're not testing people for HIV and Hep C the way that we should. And in order to stop the epidemic or curb the epidemic of HIV and Hep C, we need to diagnose these people. It is our duty, it is our job to diagnose people, both because it's their right to know, and also because it'll help slow the spread and stop impacting people in the same way. So with that, I'd love to collaborate. This is me, Alysse.Wurcel@bmc.org, and I'm so appreciative to be asked to be part of this.
Thank you very much. I really appreciate you joining us today. That's a very recent publication, and so I encourage everybody to go take a look at it. I was really struck as you were mentioning how oftentimes the proportion test for hepatitis C was lower than that for HIV, yet the prevalence of the infection was much higher for HCV than for HIV, and it's, I wonder why that increased positivity rate is not driving more testing. Do you think the injection drug use is not being picked up by the clinician? Or are they asking people, have you been tested? And people say yes, so they don't test again. What do you think are some of the reasons for this?
At least in the people who have been admitted to the hospital who use drugs, it is not a shock. Like they're coming in with rip-roaring endocarditis. I mean, I do think there is probably an iceberg situation that we're just seeing. Like there are other people we're missing that we should diagnose, probably younger people, I would say more on the pediatric side, who we maybe don't know are using drugs. I just think it's a priorities issue. I think Hep C is an outpatient issue in so many other people's minds. And I said, I want to take ownership of this as I treat people with endocarditis and as, they're throwing off septic emboli and fevering, discussions about Hep C get pushed to the wayside. And I think we're clinicians trying to do our best. There's so many patients to see, they're increasingly sick. And somehow the Hep C stuff just gets pushed down to the wayside, or they say, yeah, I was tested and that's enough, that checks the box. Just sometimes you don't even know if the patient will survive to the end of the hospitalization stay. And that's why for these very sick patients, I think Hep C just doesn't come up the same.
Thank you. Thank you so much. As a segue, John, I don't know if you have any thoughts about testing people at risk for injection drug use. Do you want to comment on that before we go into your presentation about your own experience at UW?
I think we have good access, and it seems to be pretty well integrated into settings where injection drug users are being seen, whether it's needle exchange or opioid replacement therapy sites. So I think it feels like we're doing a good job, but I don't have any statewide data to substantiate that.
Okay, fair enough. Thank you again, Dr. Wurcel. Really appreciate it. Good seeing you on here. I know you have a narrow window to shoot through here, so I know you may have to ring off earlier than the others. So thank you again. So let's turn it over to Dr. John Scott, Professor of Medicine in the Division of Allergy and Infectious Diseases and Chief of the Digital Health Office. He's the Chief Digital Health Officer for the University of Washington Medicine. John, over to you, please.
Thanks, John. So what I wanted to do is share what the state of Washington and specifically the University of Washington is doing around hepatitis C virus elimination. And just to kind of go over what I'd like to talk about in the next 15 minutes together, start out with a little bit of the background of the EPI for the state, talk about the Hep-Free WA program, and then go through some various programs that we've rolled out at the University of Washington and also at the state level. And then finally wrap up with a recent survey that one of my colleagues did to elucidate some of the barriers we have currently for screening and treatment. So I think similar to other parts of the country, the incidence of hepatitis C has been dropping. So On the left-hand side, you see in blue the number of new cases that are being reported to the state. They've been dropping steadily. You can see in red the comparison to HIV, so quite a bit higher still. On the right-hand side is the data from King County, which is the most populous county in the state of Washington, accounts for about 1/3 of all Washington residents. And what you can see in the bar graphs is that the prevalence has actually started to go down a little bit. And with that, the number of new cases has dropped. Some of that might have been a residue of the pandemic. But the thing I think is encouraging is to see that red line, which is the presumed cured, really start to tick up. Part of this is better tracking, but also I think that there's a number of other interventions that have taken place in the last 5 years that have really helped to speed that along. So we're optimistic about these lines crossing here. So that leads me to the Hep C Free Washington initiative, which was kicked off by our Governor Inslee in 2018. And the mission of Hep C Free WA is to eliminate hepatitis C in Washington State by the year 2030. I think Governor Inslee was one of the first governors in the United States to envision this as a solution for Washington. You can see some of the principles there. But I want to talk about some of the key aspects of it. The first was a statewide negotiation of the price of directly acting antivirals for not just Medicaid recipients, but also the public employees of Washington State, of which I'm one, and also all the teachers in the state. So that accounts for a lot of patients in Washington State. And so we have a very low cost compared to other parts of the country and commercial insurance for access to directly acting antivirals. Other key components of it is just tracking that data. So we have a dashboard, so we can kind of see how we're doing. We have DIS officers, folks who are investigating these reports and making sure that they're getting linked to care. And so I think that that has been an encouraging and successful program. So one of the things that we've had available to us in Washington State is Project ECHO. ECHO stands for Extension Community Health Outcomes. And I was fortunate to start that in 2008 with funding from the Robert Wood Johnson Foundation. For those of you who are not familiar, this is a case-based telementoring program similar to Morning Report, like we were educated on as trainees. And so we gather once a week by video. And we usually start off with a didactic, and then we hear cases. And usually hear 3 to 6 cases over the course of an hour and a half. And the key aspects of the program is that we have multidisciplinary panelists, so have hepatology, I'm an infectious disease. We have folks who are experts in addiction medicine. And we're primarily working with federally qualified health centers and rural health clinics. We have all kinds of learners and participants. Usually they're primary care providers, but sometimes it's pharmacists, mid-levels, nurse practitioners, PAs, and the occasional medical student and specialists who join them. So since our starting in 2008, we've heard over 25,000 cases and have reported outcomes in both the interferon era and the DA era. And it's very similar to what you'd see in phase 3 clinical trials. So that has been a great way to reach some more remote and rural parts of our state. I'm thinking right now we have about 20 to 25 regular participants in Washington, and then probably another 5 to 10 around the Pacific Northwest that would join us regularly. The second thing that I wanted folks to know about is the online curriculum that has been developed by my colleague, Dr. David Spock. Here's the link on the lower left. If you're interested, this is a program that was sponsored by the Centers for Disease Control. And it has a curriculum where you can walk through, go through the epidemiology, diagnosis, and then treatment. They have over 1,000 slides that are free and people can use if you're going to be giving a talk. And it has all the relevant trials so folks can have those for reference. And the last thing that I use quite a bit is just the clinical calculators, so like the APRI and FIB4. It's a great resource there. They have a similar one for hepatitis B as well. So in 2014, we were the recipients of a CDC grant to do population-based screening and linkage to care and treatment. And one of the most important things we did was just to try to make it easier for providers to do the testing. And so one of the interventions was at Swedish Medical Center, which is one of our large private hospitals in Seattle. And they're on Epic, and they just created a HCV screening initial management smart set so that the providers could just kind of pull this up and make it easy to order them the relevant tests. The other things that were done at other institutions were best practice alerts. So I know that sometimes those can be annoying, but these actually worked. And also we sent portal messages to patients who were in the baby boomer cohort. And then when the CDC recommendations changed to screening all adults, that also triggered an alert and also led to a surge in testing. And the last thing that our colleagues in the FQHC did was just having orders pended for testing. So the doctor didn't have to get prompted by another staff member. There was usually a medical assistant who would ask people who were in the relevant age group if they wanted to get a test, and the order was already there for them to go down the lab and get that done. So this is the data from that study. On the left here are the percent of folks who were screened in this is baby boomer cohort. And you can see at baseline it was pretty low, and at the end of the study it was over 50% of folks who were eligible for screening were getting screened. And I think the most important part was that it improved the whole care cascade at every single step. So of those people who are RNA positive, they were getting appropriate staging for treatment. They're getting access to care. And then the SVR rate was 95%, similar to what we see in many of the phase 3 studies. So I want to talk about some new innovations that have happened in the last couple of years. And this is really a result of realizing that many of the patients who have Hep C today really struggle with access to care. And so instead of asking for them to come into the clinic or come into a hospital for care, we're going out to them. So one example is the SHE Clinic, which is a low barrier walk-in clinic for persons identifying as women in North Seattle. This is an area that is known for having a fair amount of commercial sex work and also injection drug use. And they're partnering with a nonprofit called the Aurora Commons. So they provide a daily meal, coffee, mail services, and a safe space. And they have started limited primary care with chronic disease management. This is a shot of one of the rooms there. They offer STI testing and treatment, including HIV, viral hepatitis. They also provide PEP and PrEP and medications for opioid use disorder and wound care. So that's just one example. There are 2 other sites with this kind of model around King County, more in the South King County. And then at Harborview, the sexual health clinic, which is a walk-in clinic at Harborview, does screening and also can expedite treatment as well. So the other innovation that my colleagues at University of Washington has done is to really lean into our colleagues in pharmacy. So we partnered with a community pharmacy that had done quite a bit of treatment for STIs using a CDTA. And so they had experience of prescribing for chlamydia and for PrEP. And so this was a program and a model they were familiar with. And what we did is we developed a pharmacist, physician, and patient navigator collaborative care model, or PPP-CCM for short, to deliver that HCV treatment. This occurred primarily during the pandemic, so there was lots of challenges for that, but we were able to enroll 40 people who injected drugs. Their mean age was 44. Most of them were men, and about 40% were unhoused. And you can see on the right here is the care cascade for that model, where 95% of the people who were screened through a patient navigator were then linked to a pharmacist, and then 55% initiated treatment. 76% completed therapy, 70% completed SVR labs, and 91% achieved an SVR. When we surveyed the participants in the program, both the pharmacist and the patients all reported a high satisfaction with this model, and it is a program that we're hoping to expand around the state. So lastly, wanted to talk about a survey that my colleague, Paula Cox-North, conducted during 2022. This was a survey that was sent to all Washington State providers, including MDs, ARMPs, and PAs, and clinical pharmacists. This is just a high-level overview of her findings. But they found that of the 554 respondents, the response rate was pretty good at 28%. And many of these providers are operating screening, so 96%. Although a lot of them are just sending it down the lab. There's not a whole lot of point of care testing. There's still quite a bit of referral to specialists. 71% were relying on our GI, hepatology, or ID colleagues to actually do the treatment. And when they were asked why they weren't treating themselves, the most common reasons listed were just a lack of organizational support, an unfamiliarity with the billing and lab services. For those who were not treating, they also cited inadequate knowledge. And again, going back to billing as a big barrier. There were a couple of questions exploring stigma, and fortunately it was pretty low, but this was reported. 5% of the respondents reported an unwillingness to treat patients with HCV, and 8% saw inferior care of those patients who had hepatitis C. So still some progress we need to make there. So I just wanted to summarize some of the
recording in progress.
Some of the things we're working on in the state of Washington. I think having a governor to lead this effort and having that political will and having a central organized body was really important. It also underlines the importance of a partnership between public health, state government, academia, and the community. The pan-genotypic regimen, which was affordable for our medicated patients, was key. And it feels like provider education and that democratization of knowledge that we saw in Project Echo has been a huge driver of success. Don't forget to support your providers with the simplified processes and the ancillary staff. And I think as we see the current generation of hepatitis C patients and their challenges, we kind of have to rethink our care models as those patient characteristics and challenges evolve. And with that, I just wanted to acknowledge my colleagues, especially colleagues at the Department of Health, John Stockton, Amelie Rowe, my colleagues at UW, Jeff Dushin at Public Health King County, and of course, John Ward for all of his advocacy and support of this work. Thank you.
Thank you, John. That was a great overview of a longstanding program and some of the key, success factors. One of the adages in disease elimination is that the last 10% are harder to find and cure than the first 10%. And I just, with that, decreasing, prevalence and, how do you sustain interest in this program, or, the focus on testing so that you can really, complete the journey toward elimination? Do you have, any strategies to share?
Well, I just think it's keeping it in front of people, especially my colleagues. Just trying to remove any barriers in their mind, and making just the screening simple. I think that's probably the most important thing is trying to use technology, the EMR, to simplify physicians' lives is probably one of the most important things. Because we're just busy and we don't always think about it. So if there's things that can kind of help us remember to do this testing, that would probably be my takeaway advice.
Yeah, and then quickly, it looks like people still refer patients to specialists
Mhm.
rather than doing the treatment themselves, even though, with the MinMon study and others showing that it's, very implementable for primary care. Why do you think that referral still happens?
I think it's probably just kind of what they've always done, and maybe some people just don't know that they can do it. Um, so when I've seen echo work, it's usually one provider in a FQHC who will take all the referrals within that FQHC. So we don't have to get everyone. We just need to get one or two providers in a community to do this. We do have some treatment deserts where there really are no specialists able to take that, and so we're working with DOH to identify um, those areas that don't have access to specialists and trying to build it up through ECHO and some of these other initiatives.
Very good, thank you. Maybe we'll come back for some additional questions and discussion later, but let's move on to hear from Dr. Cabell Jones, who is the Research Scientist, Director of Research Programs at the Mid-Atlantic Kaiser Permanente Health System. As we mentioned at the top of the program, Dr. Jones had a family urgent event that precluded her attending in person, so she was kind enough to prepare a video presentation, which we will now hear from. Thank you.
Thank you so much for inviting me to share our story with hepatitis C testing and treatment here today. I'm Cabell Jonas, and I'm a research scientist and the Director of Research Programs with the Mid-Atlantic Permanente Medical Group, part of Kaiser Permanente Mid-Atlantic States in the Washington, D.C. area. So to provide a little bit of context about our health system, Kaiser Permanente Mid-Atlantic States is an integrated care delivery system, and we serve over 800,000 patients in the Washington, D.C., Maryland, and Northern Virginia area of the United States. We do have about 1,600 employed primary care and specialist physicians and over 250 non-physician staff. I am part of the Mid-Atlantic Permanente Research Institute, which is our embedded research institute within the Mid-Atlantic Permanente Medical Group. And so I'm going to share our journey with hepatitis C testing and treatment out here in the Mid-Atlantic States region of the United States. So this journey really started back in 2014, and it was primarily driven by the United States Preventive Services Task Force recommendation that baby boomer age patients be screened one time for hepatitis C. There were also some other factors that contributed to our redesign of our hepatitis C screening and testing pathway. So in the United States, a new technology became available, transient elastography or FibroScan, to be able to assess liver stiffness without an invasive test like a liver biopsy. At the same time, around 2014, the first curative medications for hepatitis C also became available. Inside of our health system, there's a few pressing factors that led to specific redesign elements for this program. So for example, we were looking to close specific gaps in care identified by the literature for hep C testing and treatment. We were also looking at ways to shift tasks from physicians to other care team members, making sure that each care team member could practice at the top of their license. We were also looking for innovative ways to deploy virtual care to support our patients and physicians. And then lastly, we were looking at opportunities to streamline our laboratory testing process to make hepatitis C testing very easy for patients. And so I'll start here with our results from this program. If you look at our journey from 2014 to now 2024, we started with a little over 20% of our of our baby boomer population having had hepatitis C screening. At this point in 2024, 90% of our baby boomer age patients have had hepatitis C screening at least one time. We've seen similar increases in terms of patients aged 18 to 79. Of course, this is the additional USPSTF recommendation to screen patients age 18 to 79 once for hepatitis C in the United States. So additionally, you've seen our journey start at around 42% of these patients having been screened, and now in 2024, we have about 77% of this population that has been screened one time for hepatitis C. And so how did we do this? This is an overview of our hepatitis C screening pathway, and I'll walk through this. This is a coordinator-supported cascade of testing and care. And so in the upper left-hand corner, this is the step at which we identify patients that might need hepatitis C screening. So it can be a patient age 18 to 79 per the recommendations, or any patient that's at risk for hepatitis C can be tested through this program. So the program starts with the physician initiating the testing program by placing an order. And this order might be in response to an electronic record-based alert for someone age 18 to 79 or at risk, or they can just search for the order and place it. If the initial antibody testing is negative, the physician would then communicate that directly to the patient, and it's also released through the medical record. If the initial hepatitis C antibody is positive, it's automatically reflex tested for hep C RNA, hepatitis B surface antigen, and HIV antibody. So when the patients come in, they actually give 2 tubes of blood in that initial visit so that we are able to do that reflex testing without asking patients to come back for a second blood draw. Patients that are identified to have HIV are immediately referred to infectious disease so the patient can be handled and the HIV can be taken care of in addition to the hepatitis C. For patients who are hepatitis C antibody and RNA positive, they're referred into this program where, as shown in the upper right-hand corner, the hepatitis C care coordinator shares the diagnosis with the patient. They order additional hepatitis C laboratory tests and order the FibroScan to assess liver fibrosis. They also share informational sheets and a video that I'll talk about later. Once the patient has had that conversation, they move along the program into the bottom left where they come back to the lab for those hep C assessment labs shown in the box. They also go to the gastroenterology department to have the FibroScan assessment of their liver. Coming out of that, they're given a fibrosis stage and patients are referred to gastroenterology. If a patient for some reason is not interested in treatment, they may also have their treatment deferred through primary care. But for the most part, patients are very interested in treatment and they're referred to gastroenterology, where they would start treatment, undergo monitoring in collaboration with a clinical pharmacist, and if they are appropriate for a hepatocellular carcinoma surveillance program, they would enter into that program as well, shown in the bottom right-hand corner. And on this overview of the program, I just wanted to note that the boxes in blue are the steps that are handled by the hepatitis C care coordinator, and the boxes in black are the steps handled by the physician. So we really tried to make this very hands-off for the physician and have the coordinator really step in to provide that care. So this program was specifically designed to close gaps in hepatitis C screening and care that had been identified in the literature and in clinical practice. So I've shown some of these gaps here. Of course, a very well-known gap is the issue of antibody testing and RNA testing being single tests. Implementing a reflex test for those was a key priority for this program, and we were able to do that by having the 2 tubes of blood drawn and then have the positive antibodies be reflexed to the RNA test. We also implemented co-infection testing for Hep B and HIV to be sure to detect co-infections. Communication of a Hep C diagnosis was a gap from the literature. So that was part of the design of the coordinator supported pathway, is making sure that that coordinator was able to reach out to the patient, accurately explain the diagnosis, and answer any questions. We also implemented the appropriate assessment labs and the liver stiffness assessment per literature guidelines. And we wanted to be sure to give a warm handoff to gastroenterology to make sure that that patient could access a management plan and hepatitis C curative treatment. And as I mentioned, we do have a program that connects to this one that supports ongoing liver cancer surveillance. So what were the key components that led to our program? So the first thing I wanted to talk about was leadership support. We did have strong leadership in the Mid-Atlantic states that was very supportive of both testing patients for hepatitis C and treating patients for hepatitis C. This team supported our initial baby boomer-based screening efforts and then was very supportive of the expansion of these screening efforts to the 18 to 79 testing group. Our region was an early adopter of the FibroScan technology. This allowed our physicians to access a non-invasive fibrosis assessment tool, and patients were very enthusiastic about being able to access this test in a non-invasive way. Our leadership also did provide nurse coordinator support time to be able to build a pathway that relied heavily on nurse coordinators and really preserved the physician time for the activities that required the physician expertise. So the second piece that I wanted to focus on as a key component was that reflex lab testing. We developed this in-house, but in the United States, there are many commercial labs that do reflex lab testing at this point. The main benefit for the patient is that instead of having to go twice to the lab, they now only have to go once, give that initial blood sample. For us, it's 2 tubes of blood, and then be able to get both the antibody test and the RNA result with the same samples and be able to get a complete diagnosis. So you don't have that gap of patients that got the antibody test and never came back for the RNA test. So this was a key component of this program that has contributed to it. For this particular program at our site, the patient goes for the initial laboratory blood draw, and then they come back if they're positive for the Hep C assessment labs for a second laboratory blood draw. And on that same day, they typically do the FibroScan. So we're able to reduce the number of total visits for our patients to make sure that they're coming to the clinic as little as possible and are maximizing those visits to the clinic and getting them the maximum diagnostic information out of it. When our patients see gastroenterology, they also have the option to go in person or they can do a virtual visit with the gastroenterologist. I showed the graphic of what the entire program looks like, but I always like to point out for an ordering physician, this pathway actually looks quite simple, and that was intentional to its design. So for the physician, they simply order the program initially in the medical record. And then if their patient is positive, they're sent a message at the end of the program, letting them know the updates from the coordinator, that the coordinator has completed all the testing with the patient, that the patient has been sent to gastroenterology, that the visit has been completed, and that no action from the primary care physician is needed. So primary care physicians really like this program. They like that they can do the right thing by initiating screening and ordering screening on all their patients, but that the coordinators are really handling all of that care coordination and management, making sure those patients receive a communicated diagnosis, making sure the positive patients come back for those assessment labs, making sure they complete the FibroScan, and then making sure that they actually reach gastroenterology and have that appointment and then can be triaged to treatment. So those are all things that we put on the coordinator so that the primary care physician was simply placing the order and then knew at the end of the program that their patient had completed all of those steps. So physicians are very supportive of this program in our system. So what does the nurse coordinator support look like? So we have 2 full-time nurse coordinators right now for our system, and they handle about 30 to 40 chronic Hep C patients a month. And again, their main activities are communicating the hepatitis C diagnosis to the patients, ordering those labs and the FibroScan, sharing educational information, and answering patient questions. Patients often do have a lot of questions about hepatitis C, and the coordinators are able to spend that time answering all of those questions and making sure that the patients really understand the diagnosis and understand the next steps and how they'll proceed through the rest of the system. And as I mentioned, the coordinators do provide care coordination support through to the gastroenterology specialist appointment. Once they're in gastroenterology and pursuing treatment, in our system, we have a clinical pharmacy team that supports treatment management. And so they are passed to the treatment management team to make sure that they complete their treatment. And then, as I mentioned, we have another liver cancer surveillance program that they would connect to if they're eligible for that screening. So this slide just digs in a little bit about the coordinator activities. All of our coordinator support is provided virtually, so it is telephone-based care we have one RN level coordinator and one LPN level coordinator. And so they do share the diagnosis via phone with patients. They are given a lot of time to explain the diagnosis and answer questions. They give patients informational content and follow up. We have information that is conveyed through the electronic medical record, and they can also gather and provide additional information as needed based on the patient's questions as well. The patient receives the coordinator's direct phone number. Again, for us, we want to make sure that these patients are linked in tightly with this program. And so the coordinator and the patient are in close contact via phone, so the coordinator can make sure that the patient can make it through all of these steps in the program. And as I mentioned, the care is coordinated through that final specialist appointment. So these are some examples of educational sheets we've made for the various individuals who come through this testing pathway. On the left is the general educational sheet that we provide to all ages of patients. It's a fairly general overview of hepatitis C. It explains the diagnosis. It explains how the person can care for themselves and receive more information. On the right, we actually also created a baby boomer age specific informational sheet. We found that baby boomer age patients had slightly different questions and concerns than other age patients. And so while the two informational sheets contain all of the same information, it is ordered in a different way and sometimes explained in a different way to be able to emphasize the answers to the questions that our baby boomer patients most often had and be able to put that content a little bit more forward with those patients. And so we've been able to provide really custom sheets for different groups to make sure that we're meeting their clinical needs and informational needs. So the journey of this program has been published. We have a few publications shown in the bottom left-hand corner, starting with the initial overview of the program through to some outcomes from the program. I did want to show this table from our recent publication indicating that when we looked at patients making it through each step in the Hep C testing program, we did find that more patients in the hepatitis C pathway program completed each diagnostic step, so made it to the FibroScan, made it to the GI visit, made it to treatment, and actually more patients made it to treatment through the hepatitis C program than in usual care. So in our system, the hepatitis C program is now the standard of care for all of our patients, and so anyone tested for Hep C who is an adult 18 and over will be tested through this hepatitis C testing program. So at this point in our system, 79% of our hepatitis C patients have been treated. And because this hepatitis C program and the coordinator supported nature of it has been successful with our patients, we have expanded this program to address other conditions. So for example, we have a hepatitis B testing program that again utilizes coordinators to support patients in being tested for hepatitis B and monitoring hepatitis B diagnosis and triage to specialist care. And then we also have a liver cancer surveillance program that again has coordinators support patients in accessing ongoing surveillance if they need that surveillance. So accessing the ongoing imaging and lab testing required to monitor patients at risk for liver cancer. And so those two programs are also part of our liver cancer care program here, and we have coordinating publications with those as well. As I mentioned, we've shared our journey publicly. We're always happy to answer questions about the program and share more about it, but there is a fair amount in the literature about this program and some of the outcomes that we've received. But we would encourage any interested individuals to reach out to us, and we're happy to answer questions and share more about the programs. And I did want to, again, thank our leadership who was instrumental in helping design and sustain this program. I also wanted to thank our coordinator team who does just an outstanding job with patient care, as well as our collaborating departments, particularly gastroenterology, infectious disease, primary care, our laboratory and technical teams, as well as the Research Institute team. And so thank you so much for inviting me to share today, and I look forward to hearing questions. Thank you.
Thank you so much, Dr. Jonas, for that overview. Really shows the key role a care coordinator can make in assuring people go through that cascade of care to receive the screening to set off that cascade of care toward cure. So really a lot of key lessons learned there. Let's move on now to hear from Dr. Blair Bettinger, who's the Director of Clinical Education at Care Health Center in Kansas City, Missouri. Blair?
Well, thanks everybody for inviting me to come speak. I'm joining you from Kansas City, Missouri. For those who are not familiar, it's a city of fountains, and of course we are the home of the undefeated Kansas City Chiefs, who are now 9-0 for the season. So I'm coming to you from the Kansas City Care Health Center. We're a federally qualified health center, so there's a little bit of a different perspective than the other speakers who are more part of like a health system or hospital. We are an outpatient community health center. We have several different clinics, or a network of clinics through the Kansas City region, and one of several FQHCs in the Kansas City area. So I joined Kansas City Care, which is also a Ryan White clinic. So I joined as a primary care doctor interested in treatment of HIV. And many of our patients were co-infected with hepatitis C. But then we also saw that we had a large population of patients who were just hepatitis C without HIV co-infection. And so we started a really more aggressive, active hepatitis C treatment program in 2013. And we were part of some clinical trials as well around hepatitis C drug development. So since that time, we've seen about 1,500 patients for hepatitis C who have been treated, and we have SVRs on most of those patients. We are a team, myself, a nurse, and a medical assistant, and that nurse position has been grant funded since the 2013 time. So that's really what has allowed us to kind of have a program. So we do Hep C testing with rapid Hep C tests in our clinic for patients. We have also had grant funding for that. We also have a needle exchange on site, so we're doing the rapid Hep C testings at the needle exchange. And then over time, and that's really what I'm going to be talking about today, we've developed some partnerships with outside organizations and really trying to get our staff to go there to do rapid hepatitis C testing, or to actually give them kits so that their staff can do that. And the great thing about us is we've been able to treat patients with or without a payer source. So, Missouri was not a Medicaid expansion state until just more recently here, and Kansas remains not a Medicaid expansion state. So I think for the folks on the coast who maybe had immediate Medicaid expansion, we've been left in a difficult situation where a lot of the patients remain without health insurance. So we've relied on the generosity of the patient assistance programs, and that's where the medical assistant really comes in to help navigate patients through those patient assistance programs and the paperwork needed. But we've been really successful with those, both with Gilead and AbbVie and those partners in getting those medicines. We also have referral relationships with GI specialists for patients who come in with decompensated cirrhosis, and we are lucky to have 2 liver transplant centers in the city. So we can go to the next slide here. So as I said, we were doing our thing. We were treating hepatitis C, but seeing that the world of hepatitis C certainly expands beyond the patients who show up at our door. So we made some partnerships with the Office of Viral Hepatitis through the Missouri Department of Health Senior Services has their own hepatitis C elimination for the state of Missouri plan. And kind of coming off working with them, we decided to form the Kansas City Hepatitis C Task Force. And it was our health center, the KC Care Health Center, along with another network of FQHCs called SWOPE Health. And there's a real champion of that, Rachel Melson, who's a provider there who's been giving hepatitis C care now for years and has treated many hundreds of patients and does a lot of outreach herself and has a team that's working on that. And then we're lucky to have a champion as well as the head of our Kansas City Health Department. And so Dr. Ben Grin was also highly interested in this. And the three of us really put together this task force, invited some of our colleagues and friends. You can go to the next slide. What we were looking for is, okay, yeah, this just kind of shows who we are. We can go to the next slide here. What we're trying to put together was people from the state, Missouri, the Department of Health Senior Services, the Office of Viral Hepatitis. We have our city level folks from the Public Health Department. And then we have Rachel and I's FQHCs, and we've brought in the other representatives from the other FQHCs. We have a great representative from our public hospital. So we have one public hospital, University Health, was formerly called Truman Health in the Kansas City, Missouri. And we have a GI doctor there who is a great partner. And then the real bulk of the coalition is addiction treatment centers, sober living houses, homeless service organization, methadone treatment clinics, and staff from the KC Care Needle Exchange. Basically, locations where we want to be testing people and doing outreach and doing Hep C education. And so it's really trying to get all those people together in a room, get people face to face, so that the people from the service organizations know who the people from the community health centers are. So you're not just sending off a fax or calling a number, you really know who you're talking to, and you get to meet them and talk to them. And so when we're trying to get patients to where they need to be seen, we have those relationships and that collaboration. Okay, we can go to the next slide. The stated purpose of the Elimination Task Force for the city was to reduce or eliminate hepatitis C, and we're going to be doing so by the collaboration I just talked about, by community outreach, and spreading education and awareness. And you can see our statement over there. Okay, you can go to the next slide here. I wanted to just say what I did not say was one of our members, really, and a key member, is Missouri Medicaid. So two things happened that just totally changed the game for hepatitis C treatment in the state of Missouri. And I'm hopeful that that's also going to be occurring in the state of Kansas soon. You know, after the introduction of DAAs, Missouri was not necessarily an early adopter of coverage for those, and there was actually quite a few barriers to getting treatment. So we had to do sobriety testing. We had to do and repeatedly for months. We had to wait until patients had F3 or F4 in order to access the treatment. And these were all things, of course, that we were concerned about. There was initially maybe a little bit more adversarial relationship between the public payer and the providers. But something wonderful happened. The Missouri Medicaid, MoHealthNet, adopted a stance where they would allow coverage of Mavorite. And not only that, they allow it without a prior authorization. And they took away all the fibrosis and sobriety requirements. And then they went further and became a real partner. And they are part of the Eliminate Hepatitis C coalition on the state and local level. They have their own initiative to identify Missouri Medicaid patients who have hepatitis C who have not been treated, and to share that information to providers. So, and we're really now close with the pharmacy benefit manager from the state of Missouri, and we've had a great relationship, and they've just been really proactive in trying to get patients with hepatitis C treated. So the tactics the coalition is using is the collaboration between the community health centers and the substance abuse treatment centers and homeless service centers, linking people to care, so having a real direct phone number access from the people who are doing testing at those sites to our nurses, our nurse coordinators. We have done some focus on provider development, so there is a hepatitis C echo in the state of Missouri, and there are some other training opportunities. We're trying to both do that simultaneously. I think when John Scott, the other provider, was talking about echo, we're definitely trying to increase the number of primary care doctors who are comfortable treating hepatitis C. At the same time, you know, we have a lot of areas of the state which would be considered treatment deserts. I would say many areas of the state, a patient would be unable to access treatment. So we do have a network of primary care FQHCs we're working with, but we're also integrating or working on some telehealth options for those patients in those areas of the state. So we can go to the next slide here. So, okay, this was just an example meeting agenda. We can just go to the next slide there. So on to the telemedicine collaboration. So the Missouri Department of Health Senior Services was actually helping identify hepatitis C cases through the viral hepatitis C office there at some expanded outreach testing events and some collaborative testing with some substance abuse treatment centers. Some of these areas are in rural locations, and we didn't have any providers there who were able or willing to treat hepatitis C. And so the folks from the state and myself initially got together with a plan to offer telemedicine. And that has now kind of expanded into other providers besides myself doing it, and a new partnership with the Department of Corrections. But we can just go to the next slide, and I'll just kind of go through some of the nuts and bolts of, you know, what this looks like for us. Their partnerships through DHSS actually has the patients who test positive. Initially, the staff at the state, which is, you know, basically state health department, are giving patients our information. And so patients then have the responsibility to connect to us. And we give them the direct phone number of our hepatitis C nurse. And that worked. You know, some patients definitely reached out to us, but we would get, you know, we would anticipate calls from people, and we wouldn't necessarily always get that outreach. What we really wanted was, you know, we wanted to get the patient's health information, their contact information, and be able to reach out directly to them. And so we created a MOU with DHSS to be able to access that patient data and to contact patients ourselves. And so what we can do is we can do a really directed outreach to the people. We then register them as patients at KC Care. We get some labs through LabCorp or Quest, sometimes using local hospitals. We prefer to use you know, Quest Diagnostics or LabCorp whenever possible there. And the nurse and MA obtain the results. They give them to provider, myself, to review. And once we have that, we make a telehealth appointment. And we can go to the next slide. And we conduct the telehealth appointments, talk about comorbidities, other medicines they might be on, guidance on treatment. And then what we've done is we initially were just trying to prescribe the treatment to local pharmacies. It's worked out much better to send it to a specialty pharmacy that we collaborate with and then have them mail the medicines just directly to the patients. And then from there, the nurse and MA are confirming the patients have received the medicine. They mark the start date. They're doing phone call follow-ups at 4 weeks at end of treatment. And then we get the nurse to place the order for the hepatitis C viral load for the SVR, the test of cure, 12 weeks after the last day of treatment that they've reported to us. We can go to the next slide there. So this is our future goals, but we've already actually launched into some of this. So we have expanded into Kansas. We have a great partnership with Kansas Department of Health and Environment. We have some really excited staff there that is sending us patients for telehealth treatment of hepatitis C. As I mentioned, Missouri is now able to send us the patient information directly, and we're able to outreach to them. There's an organization called the Hep C Alliance in Missouri, which is helping with outreach testing, but also helping get some of those follow-up labs on patients who remain uninsured. We do have Medicaid expansion, but we do still have patients who are uninsured, and so they're pretty great about helping link people to care, link people to the labs they need for their workups to get the care. And then what we really want, and what is now happening, is we want partnerships with our county jail, which is still in development, but then also Missouri Department of Correction, which has really taken off. So the people at the state, the Department of Health Senior Services, has made some great connections with the Department of Corrections. And now inmates before release are being signed up for Medicaid. And when they come out, we are able to get the records from the workup. Now, I'll say there's two ways that this happens. So sometimes people go into the Missouri Department of Corrections, and of course they receive hepatitis C treatment because they're in there long enough to get the treatment. But you got to be in longer than 8 or 12 weeks to get the treatment, because there's you don't necessarily see the provider immediately. They do their own workup. That takes a while to get back. And then you got to get back into them, and then they got to prescribe the treatment. So a lot of people go in for relatively short stints for drug violations, for probation violations, and they're really not going to be offered treatment. They may get some of the workup done and have the lab work done, though. And we really need to link them to care right after. But a lot of people leaving Missouri Department of Corrections are not going to an area where they have access to a doctor to treat hepatitis C. So the folks at the state level are getting their information. They're getting signed up for Medicaid, and then they're getting immediately transitioned into doing a telehealth visit. We already have their labs often have their labs from the Missouri Department of Corrections. And so we just go right into prescribing them treatment and getting them onto treatment and following them through that care. And so that's just been an excellent thing that's been happening recently. And we anticipate a lot more referrals coming our way through that work. Okay, next slide there. So that wraps up what we're doing in Kansas City, Missouri. And I just want to say a big thank you to all the collaborative partners at the Kansas City Department of Health, the Missouri Department of Senior Health and Senior Services, and then Swope Health and Rachel and all the work she's doing over there. So we have a great group of people working on this problem in Kansas City and the state of Missouri. Thank you again for inviting me.
No, thank you very much. It really shows the power of coalition building. That's why coalition is in our name, just recognizing that you really have to bring different stakeholders to the table to really get the different levels of capacity that's needed to expand access in the way that you've described. Just had a few questions for you. In regards to the coalition, so who's responsible for convening it? Is it CARE Kansas City, or is it the state or local health department, or how does that actually work? And what's the frequency of you getting together to?
Yeah, so we've gotten together, I'd say a little less frequent than quarterly, and it's Rachel and myself and Ben Grin who have been convening the meetings. We don't have any kind of anyone specifically assigned the administrative duties of managing the coalition, and I would love to see that emerge one day. But of course, that's so there's really not any like particular funded time carved out of anybody. So this is just sort of an extra effort that people are doing to try to get together and collaborate. But luckily, the time I have spent on it is something that the FQHC supports, and I know that the other FQHCs involved have supported their staff members doing it.
No, your leadership has been critical. That's plain to see. I also had a few questions just about the various aspects of the program. First of all, John Scott mentioned the subscription model for purchasing HCV medications to lower the cost per patient treated of HCV therapy. And maybe you mentioned that and I missed it, but does Missouri have that same financial relationship with a pharmaceutical company?
Yeah, something happened. So Maverick came out, and that was the game changer, because I can just share that there was some even legal battles I was involved with of trying to force Missouri Medicaid to cover, and And then everything just kind of turned on a dime when Mavericks came out. It was at a lower price, and then there was some negotiation that occurred between Missouri Medicaid and Mavericks that just totally changed the game, between AbbVie and Medicaid, that just totally changed the game. I think that they just found the right price, that Missouri Medicaid felt like this wasn't going to bankrupt them, that they could afford to treat. And then once they did, to their credit, you know, they just took a really aggressive stance on trying to get the treatment out there. And just the difference between having the sobriety requirements, and this was, you know, monthly for 3 months. I had to, you know, urine drug screens and a blood alcohol level, and waiting, you know, of course, fibrosis requirements, F3, F4, to absolutely no requirements and no PA for treatment. I mean, it was a stark night and day change, and it just really totally made the difference for our treatment program. And that all occurred prior to Medicaid expansion. So many of my patients still were just totally uninsured, and we were relying on patient assistance programs. That happened, and then Medicaid expansion happened, and now I have, you know, most of my patients on Missouri Medicaid, and so they can access the treatment with just really no barriers.
So PA is prior authorization.
Yeah.
So it's great to hear that that's been dropped as well. So it sounds like that there are absolutely no restrictions any longer.
Yes.
That's really fantastic. Your telehealth approach, I'm going to cycle back over to John to get his thoughts about this as well, but your telehealth approach is very, you know, interesting to me. It looks like you have the nurse follow up about 4 weeks after the start of treatment. Does the patient get the full 2 or 3 month prescription right up front, or do they have to go back for monthly refills?
Yeah, that's a great question. And luckily, Missouri Medicaid has made the commitment now that they give 8 weeks of medicine all at once. I am a big fan of that. You know, especially with the bulky Mavericks boxes, I just think they're hard to lose because they're just, you know, big old boxes of medicine. Now not all sometimes people have other insurance, and so that is not the case that they're going to get all 8 weeks at once. But with Missouri Medicaid, they're going to get all 8 weeks at once, and that it really does make a difference. And it's mailed to their home or to where they're staying. You know, we've had to negotiate and kind of work with some of the sober living houses or the transition living communities people are leaving incarceration and going to stay at, but they've been able to receive medicines at some of those places with a little bit of, you know, just a conversation with the right people.
Yeah. So John, just again, you may have comments and questions for each other, but what aspect of telehealth is part of your program in Seattle?
Yes, I oversee all the strategy and QI operations for telehealth. So we know we've done random chart audits to make sure that it's being done responsibly, and you know, make sure they're using the doc phrases, the document, everything, and dropping charges appropriately. In our clinic, we use telehealth primarily for follow-up, just because we feel like as a referral center, we're usually getting more of the complicated folks these days, whether they are co-infected or, you know, they have renal disease or you know, cirrhosis and things like that. So we do like to have that first visit in person. We also have a FibroScan machine, and I think that is you know, a real differentiator for us. We don't have a ton of FibroScan access around the state, but certainly follow-ups we do quite a bit, but that's worked out really well.
Mm-hmm. Do you have any questions or comments for Blair, John?
I was just interested if you are part of the University of Missouri Show Me Echo. Do you have folks that are in the Kansas City area that are participating?
Yeah, absolutely. And then, you know, the person I mentioned that does a lot of hepatitis C treatment at the other FQHC, Rachel Melson, I know she's a regular participant. It happens to fall at a time where it's difficult for me to participate. So I've been a big participant and a lead member on the HIV echo, but I have not really been a major participant in the hepatitis C one. Though my understanding it's doing great work there.
Thank you.
And I'll just say, I wish we had a better access to FibroScan. That's an area we don't really have good access, and especially for our patients who are often not in the Kansas City area. So we find ourselves really relying on FIB4 primarily.
Got it. Which can work well. Very quickly, a new testing, point of care testing for virologic positivity was just licensed by the FDA. Do either one of you see that being integrated into your care facilities?
John.
John, go first.
Yeah, so we already have reflex testing. We've had reflex testing for antibody tests for over 10 years. But I think where they could be useful would be in like needle exchange or methadone treatment facilities and things like that. So I know one of our nonprofits in the area, the Hepatitis Education Project, that would be a good place to incorporate this kind of technology more in the community.
Thank you. Blair?
You're asking about the rapid Hep C RNA?
Yeah. Yes.
The Cepheid machine. Yeah. So we have a machine. We got one for COVID testing. So we wouldn't have to buy the machine. The question is whether we should invest in the cartridges and do that at our site. I haven't pulled the trigger on that for a couple reasons. Most people come to us because they've had a rapid like finger stick Hep C antibody test, and we do a lot of that in clinic. And so we've kind of already done that. We know we need to do the RNA. So we also want to do the Hep B testing on these patients. And we've actually found several cases of Hep B, and of course we want to check if they're immune, and then we need to do our labs for our FIB4. So we kind of need to do a blood draw on patients anyways. And then, the Cepheid machine, I think people are probably aware of this. When they say rapid, they mean 60 minutes, right? So, in terms of patient flow in the clinic and keeping someone sitting there for 60 minutes to get them the result, that is also something to kind of consider. I haven't looked through the reimbursement stuff in terms of buying the cartridges and actually getting reimbursed. That's always a big consideration for an FQHC. Can we actually sustain buying those expensive cartridges? The other thing is it's a qualitative. I mean, correct me if I'm wrong. It's a qualitative test, not a quantitative test. I don't know that that's particularly meaningful because if it's if it's positive, you're going to treat. So. But it's not the same as getting a blood draw.
Thank you. We did have one late arriving question about the role of genotyping for hepatitis C in clinical practice. Please comment, both of you, starting with Blair, then John.
Yeah, generally we're not doing it. We're really trying to, for two reasons, we're really trying to minimize the amount of blood we're drawing. We have very great difficulty actually getting blood out of patients in many cases. That could be a limiting factor for treatment more than you might think. Just we can't get enough tubes, and just because of the poor venous access, and in general, it's not needed for treatment, so we're trying to minimize the expense. I know there's cases in which it would be advisable to have one, but we don't tend to encounter those very often in our broad-based treatment plans.
Thank you. John?
Yeah, we're similar as what Blair said. And I just wanted to point out that, the recent AASLD IDSA guidelines that say that genotyping is optional. I think the situations where I might want to get it would be if someone has, ongoing injection drug use or pretty recent, and in case they get reinfected. And sometimes you don't get that SVR12. You're not really totally clear if this was a failure or reinfection. But we don't want this to hold up the treatment. So if that's the last thing and we don't have it, we just go ahead and treat them. Yeah, I do want to emphasize how expensive these are. At least in our lab, people are getting charged over $500 for it. So it's not a insignificant expense. And it's ironic that, sometimes the most problematic issue for our patients is the actual cost of the labs and the workup. It's the treatment often can get covered through patient assistance or the various programs, but lab testing is not covered. So I think we need to be cognizant of that barrier for our patients.
Thank you very much. That's an excellent comment. These are pan-genotypic drugs, and the recommendations reflect that, and those are really good advice for clinical practice and the use of genotyping. So thank you very much. So I'm going to thank you all for your great presentation today, both to John and Blair, and by extension Alysse and Cabell Jonas. So again, all of this content will be available on our website, globalhep.org. And really fantastic. I really thoroughly enjoyed the webinar today, and thanks again for participating.
My pleasure. Thank you.
Bye-bye.
Thanks again for having me.
Thank you. My pleasure. Good to see you all. Thank you.